Hello everybody, I'm Dr. Sherritt. I'm a graduating third year pulmonary critical care fellow. I wanted to create a video on the approach to ICU patients and resuscitation. This is not official medical advice and it's made mainly for residents and fellows. There's a reason why this is a 3-year fellowship. This video is just to go over the basics so that you have a skeleton of how to approach these situations. Right, so I'll just go right into it. So let's go over a couple scenarios. So the first scenario is the coding patient. So this is particularly the scenario where you hear a code blue on the overhead system. You come to the patient's room, you've never seen them before in your life and they're doing CPR. How do you approach this situation? I'm not going to go over all the ACLS guidelines, right? But essentially with CPR, you're manually pumping the heart and you're manually pumping blood, oxygen, and epinephrine, okay? You're going to look at the airway, make sure they're giving oxygen. You're going to look at the quality of the CPR. All right, you can read up on ACLS on your own time. But that's actually the easy part. What causes a lot of anxiety though when people are first learning these things, I think it's that they don't have a good system for generating a wide differential. Okay, in internal medicine, you have a lot of time relatively to come up with a plan, right? You can talk to the patient. You can get sign out from other physicians. You can look at all the vitals and the labs and chart review, all of that, and you can come up with your assessment and plan, right? You can do the whole SOAP note. In these coding situations, you don't have time to go through the chart, right? So essentially what you need to do is you need to have a plan to go through these 4 categories, all right? These are the 4 categories of shock, right? I like to call it the 4 categories of death, all right? Because your patient is going to go through one or multiple of these categories. Your job is to figure out which one they're going through and then put as many roadblocks between them and the Grim Reaper as you can and go from there. So for example, you come into the room, they're doing CPR. I find it easier to come stand over here at the foot of the bed because you're going to have people doing, standing over here doing CPR. You're going to have a bunch of people by the head working on getting an airway, maybe somebody giving medications, the code card, if the room is small, it's going to be jammed in there. There's not going to be a whole lot of room in the room. So what I do is I do a toe to head exam, and what I'm thinking is these 4 categories of shock, right? So let's just start at the foot, right? Have they had any infected, diabetic ulcers, any signs of cellulitis, any signs of necrotizing fasciitis? You feel the knees and the ankles, any signs of a septic joint? Is one of the legs bigger than the others? Is there a risk that they had a DVT? Do they have any recent surgery that could have contributed to that? Do they burning with urination? Were they being treated for a UTI? Any chance that they could have infected stone, pyelonephritis, perinephric abscess? Hypovolemic, right? So did they have any diarrhea? Were they, was there any blood coming out of their rectum? Any signs of a GI bleed? Let's see, any signs of perforation, peritoneal signs when you press on their abdomen? Any ascites, SBP, hemopericardium, right? These are all distributive and hypovolemic causes of shock. Let's see, any signs that they were having a pneumonia previously or gallbladder issues? Could they have an empyema? If you have an ultrasound, can you throw it on there, see if they have an empyema? The heart, were they complaining of any chest pain? Was there any electrolyte abnormalities? QT, C prolongation, any problematic medications for that? In between CPR, you can throw an ultrasound probe there, see if there's any signs of tamponade. You can look at the lungs, see if there's any lung sliding, look for any signs of a pneumothorax. Did they have a dialysis fistula that's infected? Did they have a pacemaker or some form of equipment that could be infected? Do they have a central line that's been in there and gotten infected? Any signs of meningitis, intracranial hemorrhage, seizure, aspiration, all of those things. So there's many more than that, but you should be able to go through that whole differential in just a few seconds. Okay, and you should be, they're doing CPR, you've already assessed the quality of it, but you're essentially categorizing which of these categories the patient's in and what's most probable, right? you're going to look at see if you can get the BMP, CBC. Were there any crazy electrolyte abnormalities, like a sodium that was changing that could have caused a seizure, potassium that could have led to a heart dysrhythmia? Was there bicarbonate dropping? Any signs of kidney failure? Glucose, was it high? Was it low? White blood cell count, was this super low with neutropenia? Was it really high, suggesting that they were becoming septic? Hemoglobin, has this been dropping? Platelets, if it's really low, could they have had an intracranial hemorrhage? So that should all take you just a few seconds to do all of that. Let's back up a little bit. So if you do that, you have a wide differential. That should give you a good idea of what needs to happen once they get ROSC. So if you've identified that, okay, maybe they were having cardiogenic shock, right? They were having a STEMI, or they had a valve issue, something like that, you know that you're going to have to get an echo, official echo, or they might need some inotropes or something like that. If it's obstructive, this is typically going to need some sort of a procedure like a chest tube or pericardiocentesis, right? Distributive, you're looking at antibiotics, any past infections, anything that they've been resistant to in the past, any medications that they got that could have lowered their blood pressure, neurogenic shock, all those things. Hypovolemic shock, you're thinking a lot about access. Do I have good access to transfuse a lot of blood? Do I need to reverse any anticoagulant medications? Things like that. So here's a slide showing some of the questions that we asked on the prior slide. Again, these are not all inclusive. I just want to say two things that make everybody stressed out in the code is if they don't know if there's a pulse or not, and two, if they don't have this system in place for generating a differential. A lot of times I'll have a nurse take a Doppler ultrasound, just put it on the femoral artery. As they're doing CPR, you can hear the pulse going through there. It makes pulse checks very easy. Everybody knows exactly what to do. If they hear a pulse, then everybody knows, okay, we got to start doing post-ROSC care. But if they don't hear a pulse, then they know they need to keep doing CPR. Makes that very smooth. And then your job is to make sure that you have a good differential here, and that helps calm everybody down, because they're going to read your body language that you're calm because you know what you're doing. All right, let's go to scenario number 2. So this is the patient that you have been called to see in the ER for admission to the ICU. The two main principles here are, one, to make sure that a full diagnostic workup has been done in the ER so that nothing's been missed. And number 2, you want to make sure that the patient that is coming to your ICU is actually going to benefit. You don't want to have a scenario where you've admitted somebody and they need a service that your ICU doesn't perform or doesn't have access to. So for example, let's say there was a cardiac arrest patient, they're calling you for admission to the ICU, they haven't done a head CT, they want to admit to the ICU, you do a head CT, there's a intracranial hemorrhage, patient needs neurosurgery for whatever reason, your hospital doesn't have neurosurgery, that patient is not going to benefit coming to your ICU. They need to go to a center that has neurosurgery. It is much easier to transfer somebody to a neurosurgery center from your ER. It's much easier to do it from your ER than if they're already in your ICU. So there's things like that that you want to make sure have been taken care of on the front end. But you're essentially, you're going through the differential diagnosis with the ER physician, and you're looking for equipment, right? So do they need vasopressors? Are they on a mechanical ventilation? At my hospital, CRRT, we only do that in the ICU. Some other centers, I think they can do that on step down, but in our center, we do it in ICU, so that needs to come to us. Do they need nursing ratio, frequent neuro checks? They need some sort of drip that needs to be titrated. For asterisks, I put this here. This is like your clinical gut, all right? Like don't negate that, right? You can get all this information, but you see the patient, you just have your clinical gestalt, whatever you want to call it, is telling you that this patient might decompensate. You need to take that into account as well. For those of you fellows coming in, starting your fellowships, I would recommend having a low threshold for taking people to the ICU. You need to have a low threshold until you learn the hospital system and until you get better at this resuscitation, because if you don't accept a patient and they end up getting hurt, that's death or disability. So you don't want to miss anything. If you accept them, you can always transfer them out later. And just if you do admit somebody that really didn't need ICU, make sure that at least you're studying that case and learning why they didn't need ICU, so that you can quickly learn and properly allocate resources. Again, it's a 3-year fellowship, right? So just do what needs to be done for patient safety. All right, I want to tell you about this one story. It's to communicate this point that I don't think you're going to read in a book, but essentially what will happen in these high stakes situations, at some point you're going to experience somebody trying to practice medicine through you, and it's something that's very dangerous for the patient. They're going to be very confident trying to force you to do it. You just have to be objective, right? They're going to be emotional because they've just coded a patient or whatever, right? You have to be objective. So that's why I'm telling you, you want to start off with cardiogenic, obstructive, distributive, and hypovolemic shock. So what happened? So there was this one patient I had in the ER. He had been put on pressors, needed to come to the ICU. I'd got the call. I said, yeah, we can accept him. I was coming down to the ER, and just as I'm arriving to the ER, he develops cardiac arrest. They start doing CPR. As I get to the room, all of the ACLS is in progress. We get ROSC, and I remember the whole ER team was telling me, oh, you need to push TPA, right? They're like, this is a PE. I remember them saying, yeah, look, his head is blue, his shoulders, like, trust me, Dr. Scher, this is a PE. You need to push TPA. So what did I do? I did that whole assessment that I talked about in scenario number 1. Again, I had an ultrasound there. It didn't take very long at all to do that, but there was so much evidence that this was not a PE. I mean, the guy was not tachycardic. His oxygen saturation was high 90s on barely any oxygen. With ultrasound, his right ventricle was not dilated at all. I think we had an EKG right after ROSC, and there was no signs of right heart strain. Like, there's so much evidence that this is not a PE. And I just checked all these things automatically, right? These 4 categories of shock. And the whole ER team was telling me, you need to push TPA. But I felt very confident being like, no, we're not going to do that, because I had the system down, right? I had a good differential. But still, nothing was making sense why this guy had coded. We went through the whole thing, and while in that moment we didn't know why he coded, I did have a good understanding of what didn't happen, right? And that can give you a lot of confidence there. Essentially what happened is I ordered a CT abdomen and pelvis. I did get the CTA chest because there was so much strong pressuring to get a CT chest to look for this supposed PE. But I also ordered it because we didn't have a good differential of what caused him to code. Of course, the CT chest was negative. We did find a psoas abscess. He was supposed to be on suppressive antibiotics for some sort of a graft or hip replacement. I forget exactly what it was. Something had gotten infected in the past, and he had been non-compliant with his medications. He developed a psoas abscess, became bacteremic, sepsis, and that's why he coded from like distributive shock. So, we found that. I was able to call IR. They drained the psoas abscess like 2 hours later, and the guy didn't get TPA, right? And because of that, we were able to drain the abscess, and, he survived, and we were able to get out. But the whole point of that story is, in these resuscitation techniques, you have to develop this objective plan, because I'm telling you, you're going to experience it, somebody acting out of emotion, and they're going to try and sway what you should do, and they're going to be very confident because whatever they're suggesting, they're not going to be liable for whatever they're suggesting, but you have to focus on what's going to keep the patient safe And I'm telling you, this objective way of assessing things is a start to how you do that. So let's see, scenario number 3, this is the floor patient. This is the patient who's on the ward that needs to be transferred to the ICU. I'm going to focus particularly on the patient who is about to code. All the same principles apply, but what really helps in that scenario is if you have what I call the portable ICU. If you have 2 peripheral IVs, bag mask ventilation, and an IV pump handy, you can keep just about anybody alive long enough for the rest of the ICU team to get there, for the patient to be intubated or for them to be transferred to the ICU, central line, whatever, right? If you have this in place, you can do quite a bit, right? So if you have 2 peripheral IVs, you can intubate anybody, you can give fluids to anybody, blood products. Bag mask, you can control their respiratory status quite effectively. IV pumps, you can give pressors. Notice what's subtly here with 2 peripheral IVs. If you have a patient on the hospital ward that you have some suspicion they might decompensate later, or even somebody in the ICU, make sure they at least have 2 peripheral IVs. That gives you so much flexibility if a situation does develop, which can save somebody's life. If you have a consult from the floor and the patient obviously does not need to go to the ICU, make sure you do this thorough assessment, that you're going through all the categories of shock, that you're thoroughly evaluating the patient, and that you're offering recommendations on what can be done to ensure, or at least to create a high probability that they will stay out of the ICU for the coming days, right? Just be thorough in those consults as well. All right, so we're on to scenario number 4. This is the morning rounds follow-up. This is when you're on the ICU rotation and you're coming in the morning, you're getting sign out from the night team, you're printing your list, you're getting ready to see all the patients before attending rounds. The principle here is you need to be able to answer these 3 questions for every single ICU patient. There is so much detail involved with critical care patients. If you try to approach this through the details, you're going to get totally overwhelmed. You need to have these 3 questions so that you're keeping the big picture in focus, and that'll give context to all the details and it'll make you a lot more efficient. So for the questions are, why is this patient in the ICU? What pieces of equipment is this patient requiring? And the last one, what is your plan for removing this equipment? So for example, number 1, for example, this patient's in the ICU due to septic shock from pneumonia. All right, which is just a one-liner. What piece of equipment is this patient requiring? They are requiring 3 things: a ventilator, a central line, and vasopressors due to the pneumonia septic shock. What is your plan for removing this equipment? We're going to give antibiotics. We're going to treat the underlying pneumonia. As the body recovers, we're going to be able to pull off equipment. As you do this with patients, you're subtly also going to realize if you're not able to answer why is this patient in the ICU, then you realize that, okay, maybe they stabilized somebody, they brought them into the ICU, but the diagnosis hasn't been determined yet. So that's somebody that you're going to have to dig into soon, right away, and get the diagnosis there so that you can answer these 2 other questions. You're also going to see that in asking this 3rd question, maybe you come in the morning for this pneumonia septic shock patient and you find out that they're requiring more vasopressors and they're requiring more support on the ventilator. So what's your plan for removing the equipment? Maybe they've developed some other reason for decompensation, or maybe the antibiotics you're giving are, the bug is resistant to the treatment. So asking these questions is also going to help you detect who needs more attention and who's getting worse, and who's getting better too, right? And one last thing on equipment, try to think of equipment as a bridge, right? It doesn't essentially treat a patient. Like when you put a patient on a ventilator, let's say for pneumonia, you are using that ventilator as a bridge until their lungs recover and they can be taken off the ventilator, right? So when you're thinking about escalating therapy, using more equipment, you need to be thinking, is this equipment actually going to lead to a cure, or is it just buying time? Those are things that you need to be aware of. All right, this last scenario, number 5, is when you are called by an outside hospital and they are requesting transfer to your ICU. The big question is the patient safe for transfer? You want to ask a lot of questions. You want to go through all those categories of shock. You want to make sure that they're not missing anything. They could tell you, oh, the patient has AFib, RVR, they need to come to a step down or ICU, and when they arrive at your ICU, they're in AFib, RVR because of hypovolemic or distributive shock, right? So when you're getting that phone call, you don't want to take what they're telling you the diagnosis is as truth. You want to ask them a lot of questions, make sure that they've done a full assessment, so that there's not going to be any surprises when the patient shows up. And maybe they don't have an exact diagnosis, but after that phone call, there should be a good understanding of what it is not, and if the patient is safe for transfer. All right, so what is this? This is the icon for the Echo Tools app on the App Store. You can download it for free. I'd recommend you get this and explore this app. It's going to help you a lot with learning your basic ultrasound exams. To finish off the video, I'm going to show you some practice cases. This is mainly, I'm just going to show you pictures that I found on the internet, and I'm going to show you, it's not a shortcut, but if you use those 3 questions that I've mentioned earlier about why is the patient in the ICU, what equipment are they on, and what's my plan to get it off, I'm going to show you just kind of a practical application of that, and just a way that you can get oriented. Let's say you walk into the patient's room first thing in the morning at shift change. You don't know anything about them yet, and you have to immediately respond to something. This is something that can help you get up to speed quickly. So for example, let's say you walk in at the morning, you see this, there's your colleague, he admitted this patient overnight. First thing I'm going to do is I'm going to look at the vitals. I can see he's got a normal heart rate, blood pressure's okay, saturations are okay. Immediately I'm going to qualify those vitals. Okay, so you can see on the top right, FiO2 at 21. So his saturations are good, and he's not really requiring much support on the ventilator to maintain that. His blood pressure and heart rate are normal, and he's not requiring any pressors to maintain that. So I already have a brief understanding that his vital signs are not requiring much support. That's not why he's in the ICU. Over here, you can see a EEG tech is looking for a seizure. That's what that equipment is. So even though I don't know anything about this guy, I can just guess by looking at this photo that he's probably in the ICU. He had something neurological happen. Maybe they're trying to rule out a seizure. Maybe he had a stroke. Maybe he had a bleed. We need to have a neurological plan in place before we can pull the ventilator out. He's probably on the ventilator because he's got altered mental status from whatever intracranial event happened, and that ventilator is just protecting his airway, right? So of course you got to do your own assessment, and this is a super simplification, but you should be able to walk into a room, you should be able to look at the vitals, look at the equipment, and you should be able to come up with the most probable reason why they're in the ICU. Here is another picture I found on the internet. So if I were to walk in the room and I look at the vitals are okay. This patient is on vasopressors. The room air is not requiring any support for saturations, tolerating room air. I would ask any nursing staff if the vasopressors were going up or down to give me an idea if things are getting better or worse. And then I'd see this piece of equipment, and without knowing anything else with the patient, I could guess that this patient is most likely in the ICU due to some sort of a urinary infection or obstruction that got infected. We're going to be able to get this patient off vasopressors as we drain this obstruction and give antibiotics. And again, of course, I'm going to do a full assessment, make sure there's nothing else going on. But if I, walked into the room, I would already know the most probable reason why the patient is there. This is a ECMO circuit. It provides oxygenation when the lungs are unable to do that task. So if you see this, one of the things you might be thinking of right when you walk into the room is ARDS. This is an Impella device. If you were to see one of these, it would be a very good guess to say that the patient perhaps had some form of cardiogenic shock. Maybe they had a MI and they received PCI overnight, and they're on this device to be weaned off until the heart can recover. So if you were to walk into the room, you might guess that this patient is in the ICU for pericardial effusion causing tamponade and obstructive shock. You would drain the effusion, and then to get them out of the ICU, you would follow up that drainage fluid, find out what was causing the tamponade, make any changes to prevent it from coming back, and that's how you get them out of the ICU. The cases where I've seen of this, it's either one, they're initially confused as hypovolemic shock, or number two, they have some other diagnosis, like septic shock, something else. But in your initial assessment, you also check the heart and you find out they also have tamponade. So make sure you're doing all those scans. A lot of times I've found that these tend to be related to myocarditis from a prior infection or malignancy. This is a rapid infuser. It's really good for treating hypovolemic shock. If I were to see one of these inside the patient room or standing right outside, I would guess that the patient was in the ICU for hypovolemic shock. They potentially are on pressors because of ongoing blood loss, and we're going to get them out of the ICU by finding out where they're bleeding and then stopping that bleeding and then stabilizing them until they don't need pressors anymore. So this is another picture I found on the internet. If you were to walk in the room and see this, you would think this patient is in the ICU for a multi-organ failure. I'll have to get the sign out, check the chart, the history, find out exactly why. He's on multiple different pieces of equipment, CRRT, intubation, probably multiple different pressors here. To get him off of that, he's going to need a lot of work. In summary, when you're dealing with these situations, you want to have a wide differential so that you're able to act objectively. You can do that by focusing on cardiogenic, obstructive, distributive, and hypovolemic shock. When patients are in the ICU, you want to know why they're in the ICU. You want to know what type of equipment they're on, and you want to have a plan for de-escalating that equipment. This is a very complex process. I've tried to make it the basic foundations and principles. I've tried to simplify that. There's a lot more study. You'll notice I didn't talk about trends. For example, you're treating a patient for hypovolemic shock and they're still getting worse. Like, what do you do next? Or septic shock, they were getting better, now they're getting worse. Now what do you do? There's a lot more study, but hopefully this gives you some foundational principles that can help get you started. I hope this video was useful.